Thanks so much. And just for everybody on the Zoom, if you are not a committee member or presenting the bills at this time, you don't need to keep your cameras on. Well, you can turn it on when it's your time. So hello, everyone. I'd like to go ahead and call to order the Tuesday, March 9th meeting of the Senate Committee on Health and Human Services. We'll go ahead and just do a verbal roll call. I see that Senators Harris, Keffer, and Hardy are here, and it looks like we are still waiting for Senator Spearman. Please mark her present when she arrives. Wanted to just do the brief introduction. I know folks are figuring it out, but let's just make sure. So there are many ways that you can participate with us here in the legislative session, and that includes sending in written testimony, using our opinion poll on our website, registering and signing up to testify, sending emails to your senator or the members of the committee. I encourage you to do all of that. If you are having any challenges figuring out how to do that, if you Google the Nevada Legislature and get onto our website, there's a help bar. And if you go on that help bar, it'll help you to figure it out. And if that's not working, on our agenda is an email address, and you can send an email to the committee manager and she'd be happy to help you out as well. Today, just wanted to talk about what we're going to do. We're going to be hearing two bills, SB 5 and SB 40. Both of these bills are presented by the Patient Protection Commission. There has been a lot of interest in these bills. And so just by way of process, we do have the bill presenter with us on the Zoom. And then we also have folks who are interested in presenting an amendment. We'll allow the executive director of the Patient Protection Commission to make her bill presentation with the length of time that it takes. For those who are proposing amendments, we'll do that under support, opposition, or neutral. So you'll need to pick your lane, and then we will give you 3 minutes to present the contents of the amendments. But we have you on the Zoom call here so that if members have questions, that there's an opportunity for them to answer those questions. Once we move through the folks who are on the Zoom call, we will then also go to the phone lines to also do support, opposition, and neutral. So just want everybody to anticipate the process there. We'll do all the support at once, all the opposition at once, and all the neutral at once, regardless of which format folks are in. With that, I think we are ready to go ahead and open up the hearing on Senate Bill 5. Ms. Shalhagian, whenever you're ready.
I think I have to unmute myself. Thank you so much, Chair Ratty, members of the committee. My name is Sarah Shalhagian for the record. I serve as the Executive Director for Nevada's Patient Protection Commission. First, let me just say thank you so much for giving me the opportunity to come before you to present these two measures and to show you all the work that the Commission put into these requests. So I think that what I'd like to do, Chair Ratty, is kind of give a high-level overview of the Commission, talk about their work, and start by also talking about the process and how these measures came about. So the Nevada Patient Protection Commission was created by Senate Bill 544 last legislative session. It was a measure sponsored by Governor Sisolak and received unanimous bipartisan support in its passage. The commission is comprised of a multifaceted team of healthcare experts, advocates, and providers and industries charged with systematically reviewing issues related to the healthcare needs of Nevada residents, to the quality, accessibility, and affordability of healthcare. In addition, the commission is charged with making informed recommendations to the governor designed to improve healthcare for all Nevadans. In addition to their informed recommendations, this body has the ability to request bill draft measures for each legislative session. So these two measures in front of you are a product of those recommendations and utilizing their ability to request these bills. The 11 members that are voting members on this commission all serve the commission as an appointee of the governor. And we also have ex officio members who help support the commission as technical advisors, and they are Director Richard Whitley, Insurance Commissioner Barbara Richardson, and the Executive Director of the Silver State Health Insurance Exchange. What I'd like to do is just tell you a little bit about the Commission's work. And so the Commission held its first meeting last year on February 3rd and met one more time on March 2nd before Governor Sisolak made a declaration of emergency in the state of Nevada to address, contain, and mitigate the effects of COVID-19. Several meetings were postponed as the Commission followed his directives and guidelines for hosting public meetings. On May 19th, he requested for this commission prioritize its work to best serve Nevada in this time of state and national emergency, specifically asking for the assistance with recommendations around the long-term recovery for our state. On June 9th, the commission held its first virtual meeting and agreed to refocus the commission's priorities. What is in front of you today is a product of a lot of deliberation from the commission. They met 12 times last year. I actually thought it was 11, and I forgot one of the first ones. I previously reported that over to the other House and Assembly, but they actually met 12 times last year and 9 times prior to their 6-hour work session in which the commission discussed, debated, and voted on a working document to produce the first measure I'm going to talk about, which is Senate Bill 5. So Senate Bill 5, the goal of Senate Bill 5 is to, next one. So the approved working document is what outlines this commission's request. And so the bill seeks to enact legislation to codify telehealth flexibilities granted during the COVID-19 public health emergency. Specifically, it is aimed to increase patient access to high quality care while reducing costs and improving patient and provider safety through the inclusion of clear, effective, and sustainable telehealth medicine in our Nevada revised statutes. That is a long way for me to say that really the commission had a lot of discussion and deliberation and saw that patients were kind of told to stay home and during the pandemic, and they saw an increase of access to health care was increased by the utilization of telehealth services. So the commission saw a great deal of value in improving access, and as a new way forward, felt that having this measure in front of you was a part of that long-term recovery for our state to improve access to patient care. Specifically, the request does 2 things. It expands service through establishing an all-payer parity, which requires each third-party payer to cover services provided through telehealth, except for those using the standard telephone, in which the commission wanted to make sure that it maintained the access, but did not also require payment parity through the use of a standard telephone. The second portion of this measure addresses equitable access. And so the second part of it requires the Department of Health and Human Services to establish a data dashboard that allows for the analysis of data relating to access to telehealth by different groups and populations in this state. Further, this piece, it requires that the state use and evaluate the dashboard to make access more equitable. And it also requires not only the commission, but the Patient Protection Commission, the Commission on Behavioral Health, the 5 regional policy boards, and the Legislative Committee on Healthcare to include this data dashboard in their review of their duties. And I'm actually available for any questions.
Thank you, Ms. Shalhagian. Members of the committee, would you like a walkthrough of the bill? Or would you like to just jump into questions?
I'll have questions, Madam Chair. If you want to go to questions.
See some nodding. Everybody's good with just questions? All right, Senator Kieckhofer, did you have questions you'd like to start with?
Thank you. Just a couple, probably off the bat to be simple. So a standard telephone is not a cellular telephone? Standard in today's operating nomenclature, right?
Thank you for the question, Senator Kieckhofer. Chair Ratty, through you to Senator Kieckhofer. I believe it does. That is a modality that is it just means standard telephone, but I would like to kind of push that off to somebody who may know that better than me, and I've got Dwayne on the line, and he may be able to answer that to you, your question specifically.
Good afternoon, committee. Dwayne Young, Deputy Administrator for the Division of Healthcare Financing and Policy for the record. This language is existing in standard NRS, and it does reply to what we would consider both a landline and cellular device.
So if the definition changes, I'm trying to make sure I find the right chapter. I know I highlighted the definition somewhere. Term includes, I can't find it. So is the provision of telehealth, the provision of telehealth will include services provided through a standard telephone, but they can be billed differently. Am I reading that correctly?
Dwayne Young, Deputy Administrator for the Division of Healthcare Financing and Policy, yes. Currently, telephone is restricted by the federal government because it is a non-HIPAA compliant platform, and that federal CFR is actually governed by the Office of Civil Rights within the Department of Justice. Existing language in 422 says to the extent applicable. That is on page 7, section 8, under section 21, line 14. And so we believe that gives this bill the authority to allow telephone, if it were to be allowed by the federal government, to the extent applicable, but then also does set up that the division, except for services provided using standard telephone the same amount, has the discrepancy to not pay parity. Chapter 422 requires parity for in-person services and telehealth. So this would allow us to set up a separate modifier for telephone delivered services, and we could pay them at a different rate than what we have paid traditional telehealth or in-person visits. And part of this language, Ms. Shalhagian and I both serve as part of the Western States Compact for the governor's office. And this is something that other states have done so that when they do face a budget shortfall or crisis, they don't have to cut rates across the board, but they can set up a discrepancy in payment from those services delivered via telehealth versus those by telephone only, particularly when they're dealing with providers who are cost-based reimbursed. And the challenges of buying telehealth equipment or setting up shop for in-person visits are taken into consideration in building those rates as opposed to operating in simple telephone call.
And let me just interrupt here for Ms. Shalhagian. For the remainder of today's meeting, you can go direct to the senator.
Okay, great. Thank you.
Senator Kiefer, go ahead.
Thank you. So with, if I'm using an app on my telephone, am I using a telephone or am I using a technology service that's in the broader definition of telehealth?
Dwayne Young, Deputy Administrator for the record. Again, thank you for the question. And that is the modality. And so if this is a standard telehealth visit, there are audio-visual requirements. If it is telephone, there is a certain audio requirement. There are apps that utilize remote patient monitoring codes. Those are different CPT codes that are billed, usually in conjunction with another visit. Nevada does not currently cover those codes. And so usually working through an app, through a health app, is not part of the reimbursed process in working with a physician currently. While we're on the definition, and I know that we'll get it presented later, there's some discussion about the types of definitions that are allowed. And I think it was the definition being provided by synchronous or asynchronous technology. Is it your belief that that definition is currently covered under our existing statute? Again, Dwayne Young, Deputy Administrator for the record, yes, it is our belief that is covered under 422,
Okay.
our section that governs Nevada Medicaid.
Okay.
And Senator, everybody else on the committee has their hand up. So if it's okay with you, I'm going to jump to some other folks and then come back around to you? Does that work?
Thank you. Yeah, absolutely.
Okay. Senator Harris.
Thank you, Chair Ratty. I had a question about who would be able to access this kind of all-payer system. Is the information kind of aggregate and anonymized? Who's got the ability to kind of pull information from that bill?
So Senator Harris, I believe that there might be some confusion because both bills have a data collection component, but the claims database is actually Senate Bill 40 as opposed to Senate Bill 5. And I completely understand why you may be confused by that because I was earlier, but this bill does have some data collection components. So Ms. Shalhagian, could you talk about the data collection components in this bill?
Sure. Thank you, Senator Ratty. Yes, so this is not a data collection bill that mirrors what the Senate Bill 40 does. This is a data collection bill that really puts the burden on the state to utilize existing resources. So the data collection efforts are all done within the state, and there's no burden on any of the payers or insurers to submit any data for the dashboard. So the intent is for the state to utilize existing information to create the dashboard. I think the idea behind it was you can't improve what you can't measure. And so when you look at health equity and wanting to make sure that you address equitable access for patients in our state, you wanted to have some sort of measurement of that. And so this creation of the data dashboard is the first step to measure telehealth access to address equitable access and to start looking at a vulnerable population.
And so am I understanding you correct that only whomever, I guess, is the administrator of this would have access to the data itself, and the rest would just kind of be publicly available in the dashboard?
Thank you for the question, Senator Harris. So in sections 1, 2, 3, 5, and 6 of this bill, that establishes the parameters for the State Department of Health and Human Services to create this data dashboard. And there is a requirement that it get posted on their website as well as the Patient Protection Commission's website. So if you're familiar with some of the amazing data dashboards that the state has produced related to COVID-19, it's very similar to that. So they're going to create a data dashboard that will be housed on their site as well as the Patient Protection Commission, so all the consumers can see and access that data. However, it is created by the Department of Health and Human Services. And then so there's no data release or request for it because it's about a data dashboard creation.
And Chair Ratty, if I may, just one additional follow-up. Thank you. Is it going to be the Department of Health and Human Services that will put into place all of the protections around that data, right? So when you get personalized data, you want to see, okay, well, we've got a 5-year limit, or all of these kind of protections in place about how it's allowed to be used and who can control it. So is that where we're going to see that?
Senator Harris, I'm going to jump in here on this one. So this bill doesn't contemplate any new data collection. So it only uses the data that the state already has. So for example, Medicaid claims that are covered by HIPAA and all of the rules for Medicaid, or the number of individuals who are receiving respite care, but it's only the data that the state already owns. What the bill is asking is that we have all this data, and there's actually an effort in the Department of Health and Human Services now to create specifically a data unit, or they're pulling all their statistician data type folks into one unit. What it asks is that when we're sharing that data, that we do it in a dashboard that makes that data understandable to the general public and all of us. So it is less about new data. So whatever protections are currently in place for that data still stands, and this bill doesn't do anything about that. The next bill, again, lots of questions about that data because it's a new data, but this bill is really just about taking the data that we currently have that is currently under existing protections I'm presenting it in a way that it's useful. Does that help?
It does. Yes. I just, I worry a bit about, consumer protection, and anytime you centralize a bunch of data, even if you already had access to it, there's some questions, but that makes sense. Thank you.
And perhaps, Ms. Shalhagian, you could speak to the nature of how this data is intended to be presented. I'm assuming aggregate and de-identified. There's nothing in the dashboard that would have any individual records or any information about any individual patient. Is that accurate?
Right. Thank you, Senator Ratty. I believe that is accurate. And later on in the bill hearing, under testimony, there is a amendment from DPBH that addresses some of the data dashboard kind of creation, mostly related to the fiscal note. But Kyra Morgan is available to answer questions, and she could speak to that better than I can. But you are correct in my understanding.
Actually, I think that's a great idea. Kyra, could you jump in and talk about how data that the state currently has is currently protected?
I think I just froze. Can you guys hear me?
You're a little bit quiet. Can you lean in a bit?
Yeah, Kyra Morgan, for the record, I'm the state biostatistician for the Department of Health and Human Services, and that's absolutely correct. All of the data that would be presented in the data dashboard and our amendment will speak more to this in public comment, but all the data that we would present would be aggregate. There would not be anything to identify a person on an individual level.
Senator Harris, any questions given that we have the person who's actually in charge of data for DHHS on the line?
No, that's okay. I have faith that, our department is handling people's health information appropriately. So no issues. Thank you.
Great. Thank you. Senator Hardy.
Thank you, Madam Chair. Thank you, Madam Chair. I guess I have the same kind of confused questions. I look at section 1, subsection 2 of A, allow the user, which is apparently, quote, different groups and populations, the analysis of telehealth by different groups and populations, and then use that for ethnicity, ancestry, national origin, color, sex, sexual. Do we actually have that for individual people that then can be disaggregated? Or I'm not sure how you did that and then how you use it. I guess it's too basic of a question. I guess I'm a little lost.
Ms. Morgan, do you want to take a crack at that one?
Yeah, again, this is Kyra Morgan, for the record, Department of Health and Human Services. That's actually really applicable to the amendment that we submitted from DA, which really just adds language around the dashboard being contingent on what data is actually available and within federal regulation for us to collect and present. And some of that is not going to be data that's available right now. And so it's likely that the dashboard will be a subset of what's actually, I think, the big goal from the Patient Protection Commission, but we'll be able to include at an aggregate level as much information as possible.
So what are you going to do with it? More basic, what's the point? I guess I'm missing the whole thing. We've got a data dashboard. What are we going to do with it?
Ms. Shalhagian.
Thank you so much for the question, Senator Hardy. So the intent of the data dashboard is really to be the first step to measure telehealth access and to address equitable access and look into vulnerable populations. So it requires the department to include in their evaluation of telehealth services that data dashboard. So it's required two-part. One, that the Department of Health and Human Services must create it, and then two, they must utilize it in their decision-making process. In addition to that, it also ties in the other advisory boards in the state, Patient Protection Commission included, Commission on Behavioral Health, the 5 regional behavioral health policy boards, as well as a legislative committee on healthcare to also review the data dashboard and include that in their review of their own policy. So it's, again, looking at the long-term recovery and really aiming at addressing health equity to make sure that we create this data, we have the good data, you have it available, we should be reviewing it and putting it into consideration for future policy decisions. In addition to that, there is the housing it on the Patient Protection Commission's website. The thought behind that was to make sure that patients and consumers were able to easily access and review that themselves and also be able to opine on it.
Thank you. And I should remind you to put your name on the record each time, just so our secretaries have an easier time of it. Senator Hardy?
So is someone else doing this and it's working somewhere?
Thank you for the question, Senator Hardy. Sarah Shalhagian for the record. I don't know specifically, but I think that, and Dwayne may be able to help me, but I believe the state of Colorado is doing this, and that they have built a equitable dashboard that kind of is in the same thought process as what the commission's intent was, but I found that out after the fact. And so I believe Colorado is doing it, but I'm not aware of any other state that is doing it. And Dwayne might be able to speak to that too, because as he mentioned earlier, we're a part of this telehealth subcommittee together, and that's a multi-state collaborative.
Dwayne Young, Deputy Administrator for Medicaid, for the record. Yes, as Ms. Shalhagian has pointed out, Colorado has done this. I don't think that particularly influenced the decision of the Patient Protection Commission, but there are other states within those Western states compacts, such as California, that are looking at this as well. As far as having the data for telehealth to Medicaid policy, I think it's very important to have this data. Senator Hardy, in your district, as you know, has heavily relied on telehealth in some of the more rural parts, the same as they have in Senator Harris's district in some of the more urban areas where we know they don't necessarily have the infrastructure and had a difficult transition in the pandemic. And so really having this types of data and knowing how the services would deliver will help us to figure out how to more equitably address grants when they are available, as the department has given out telehealth grants in the past, and also how to better support providers who have not made that transition or are having difficulty making that transition.
I appreciate that. Thank you. Thank you, Chair.
You bet. I'm going to give Senator Spearman a shot, but before she jumps in, I just want to clarify something that you just said, Deputy Director Young. So as an example here, we may not know the race, gender, ethnicity of an individual patient, but we may be able to see utilization patterns within, say, the Medicaid telehealth utilization. And we may be able to overlay that with neighborhoods where we have census information, where we might know there are a higher concentration of people of color, for example. And that would give us not a patient by patient piece of information, but it would give us meaningful information in terms of equity and how we are doing in terms of access to services, looking at folks who have generally not had access, people of color, lower income neighborhoods, et cetera. Is that the idea?
Dwayne Young, for the record, yes, that is the idea.
Okay, thank you. Senator Spearman.
Thank you, Madam Chair. Most of my questions were already answered, but so the data that you're collecting, there are about, I think the last four categories there would be SOGI, sexual orientation, gender identity. You all have the ability to share that information so that it's not just one particular portion of healthcare, and then we don't have the information for another. And obviously with the information, the personal information redacted, once you collect that, do you have the ability to share that with other internal agencies or not?
Thank you for the question, Senator Spearman. The intent is to share the information. The intent is to have it housed on the DHH website as well as the Patient Protection Commission's website, and for those other public bodies that I referenced earlier to review the dashboard. So I think Kyra could speak to maybe more specificity on if I'm not answering your question, but I think that I'm sorry, I'm not sure I completely understand it, but the intent is to share the information to not only the public bodies, but to the public and to all those consumers.
Okay. All right. And policy will be directed based upon that. For example, if you're looking at one particular demographic and that's been hit hardest with COVID, you will direct resources to that community so that the underlying morbidities would be addressed when the other pandemic comes, because we know it's not an if, it's a when the other pandemic comes. And be able to do some things in terms of education, not just education for prevention, but not just addressing those comorbidities. So thank you. It's been helpful.
Thank you.
All right. So I think everybody's had a shot. We can go around for another round. Other questions on the presentation of the bill? Senator Keycuffer.
Thank you, Madam Chair. A lot of my questions were asked and answered. I appreciate it. On the data analysis and the policy recommendations, you're specifically asking for 8 different boards to provide policy advice to you. Are you sure you want that much feedback?
Thank you so much, Senator Keycuffer. Sarah Shalhagian for the record. The intent is just to have them included in their review process. Whether they make it a priority is going to be at the discretion of each public body. It's just making it known that we intend for the data dashboard to be created and to be reviewed. And so what level of priority those bodies choose to utilize the dashboard is going to be at their discretion.
Thank you for that. And then my follow-up question on the telehealth issue was related to behavioral health parity and whether this creates a disparity for behavioral health services in terms of reimbursement disparities using solely telephonic means, if you understand what I'm asking.
Thank you for the question, Senator Keycuffer. Sarah Shalhagian for the record. I believe I understand what you're saying, but I think Dwayne may be able to speak to it more specifically than I can.
And Senator, perhaps you could clarify your question, because there's two things in there: behavioral health parity versus modality parity.
Right. So behavioral health services might be maybe fully adequate provided over a telephonic means.
They're better positioned to use that modality.
Right, and up to the physician to do that, but then we are reducing reimbursement for a service that may be fully appropriate for a telephonic service.
Sure.
We have our ongoing requirement for behavioral health parity. Right?
Yeah.
Great. Thank you for that clarification.
Thank you so much for your question, Senator Keycuffer. Sarah Shalhagian for the record. So I think the intent of the Commission's bill draft really was allowing for increased access through payment parity on the insurer side, or all payer parity, but recognizing that the use of a standard telephone may not warrant the same type of payment parity or standard of care. And so the Commission did not want to restrict the use of a standard telephone or telephonic, but also recognize that it may not be they don't want to change the standard of care in the sense that saying that it's the same as in-person service. Did I answer your question?
I guess just to flesh it out a little bit, was there discussion had about whether that was an appropriate decision for mental health services as well as physical health care?
Thank you for the question, Senator Keycuffer. Sarah Shalhagian for the record. There was discussion about about telehealth access particularly for behavioral health, but it was not included specifically in this measure.
I appreciate it. Thank you.
Second round for anybody else. Senator Spearman, you still have your virtual hand up, but I'm not sure if that's a leftover from the last round. Okay. All right, so then I will ask, and this might be more for Deputy Director Young, but my understanding is there's movement at the national level that we're in a little bit of an uncertain time right now in terms of reimbursement for telephone only or voice only versus a full, true telehealth solution. And we're kind of waiting to see how that landscape works. So I think if we were to say we wanted telephone to be fully within parity right now, we would be also saying that the state would have to pay 100% of that because it's not currently a Medicaid reimbursement, but that we're anticipating or waiting to find out if the federal government moves on that. And so I think I heard you say earlier that the bill is written in such a way that if there is movement, then we could benefit from that and therefore Nevadans could benefit from that. But could you just tell us a little bit more about that piece?
Certainly. Thank you, Senator Ratty, for the question. Again, for the record, Dwayne Young, Deputy Administrator for Nevada Medicaid. And so I believe I'll take the first piece of that question, which was, yes, there are conversations at the federal level. As I stated earlier, this is a CFR that is governed by the Office of Civil Rights under HIPAA, which is then under the Department of Justice. During the pandemic and during the declaration of the public health emergency, the Office of Civil Rights made non-HIPAA compliant platforms, which include telephone. They decided not to enforce the prohibition on those. And so CMS then provided a directive that this could be reimbursed and utilized. The state then covered it in its 1135 waiver. So we are currently reimbursing for telephone services with certain exceptions. Back to the language of the chapter, we believe that if the federal government were to take movement on this, the language that was existing within this law that was not modified, that says to the extent applicable, applies to us being able to get actual reimbursement or match. And so we have interpreted that as our ability that if the federal government were to allow this and we were to get matched, then we would certainly continue those flexibilities. If not, we would continue along operating under 422, the telehealth provisions as cited in our chapter as we have been. We also see that this not changing that language also gives us the discretion, as we have used during the pandemic through our COVID memos, to provide further guidance about services that weren't traditionally allowed for telehealth and services that were traditionally allowed for telehealth, but certainly not appropriate for telephone. And we have done that with some rehabilitative mental health services as well as some health services on the medical side as well, and provided those guidances on our website and in announcements out to providers. And so we don't see this bill as changing anything under our operations, but really allowing for that enhancement and allowing for us to take advantage, should the federal government move on this in a different way, to then craft some parameters in permanent policy around the reimbursement for telephone services if reimbursed by the federal government.
Okay, great. But the federal government would have to address the HIPAA issue and then CMS would have to address the reimbursement issue.
Correct.
Okay, helpful. Thank you. Any other questions from the committee before we move to public testimony? Okay. So we're going to go ahead and start with those who would like to testify in support. And so is there anybody on the line who would like to testify in support of SB 5? And this is within the Zoom that's in the support, but has an amendment. So I'm just unclear, DHHS, American Telemedicine Association, and Teledoc, if you're here to testify in support of the bill generally, and then just to suggest the amendment. So I see some nodding. Okay, great. So, and in DHHS, I'm assuming you will need to be in neutral. Kyra, is that correct? Okay, great. So let's go ahead and start with Claudia Tucker from Teledoc. You have 3 minutes to present your support and the amendment.
Good afternoon, Madam Chair, members of the committee. My name is Claudia Duck Tucker. I'm Senior Vice President of Government Affairs and Public Policy at Teladoc Health. I've testified before this body before, so I will forego the definition of Teladoc and what we do and jump right into the meat of the matter here. We support this bill. While we were not engaged with the work of the Patient Protection Commission, quite frankly, I was unaware of it, but we have met virtually and on the phone with Ms. Shalhagian and really appreciate the work that she has done. We support their mission to enact legislation that codifies the telehealth flexibilities that were granted during COVID-19, during the public health emergency. Thing number two, done properly, the clarification of the telehealth statutes will ensure that the latest innovations in technology, such as asynchronous communications, are compliant with Nevada state law to allow remote patient monitoring, which is critical to those folks who have diabetes and cardiovascular disease. Lastly, we encourage language that will allow for expanded access to expert medical second opinion services to the best specialists in the country without incurring the cost and inconvenience of travel. We support the work that the legislature is doing to help increase access to telehealth treatment. The ability to use the telephone to expand the reach of mental health services to those who need it is critical. The healthcare provider shortage is real. However, in rural areas, getting an in-person appointment with a mental health provider is nearly impossible. 60% of U.S. counties have no practicing psychiatrist and general medical access. Telehealth is able to fill this gap with quality health care. And I stand ready for questions should you have them.
All right, committee members, you should have an amendment labeled SB5 amendment request submitted by Marcus Conklin, Strategies 360 on behalf of Teladoc. And so it's focused on the definition and some of the other pieces. Are there any questions on this portion? All right, not seeing any, I would like to jump in. I think what we understand from our legal counsel is that the definition is inclusive and that if we start actually listing things out, we may have some unintended consequences. And so I wanted to call in Eric Robbins. I guess well, let me start with you, Ms. Tucker. Why is it that you think that the bill as written doesn't include the technologies that you're concerned about?
I think that it's unclear. It's quite clear to me, Madam Chair, but I live this every single day. And for our clients, a layman's reading of this is not clear. I know that because they've asked me questions. And I think that any time that we can clarify statutes so that everyone understands it, we're all better for it.
Okay. So, Mr. Robbins, would you like to speak to what you think the bill says or does in terms of inclusivity and clarity?
Sure, I can do that. So this is mainly dealing with more the existing language of NRS 629.515. And I'll just say a couple of things about this. So first of all, the definition talks about the use of information and audiovisual communication technology. I don't interpret that "and" to mean that you have to have both or it's not telehealth. I mean, it can be either one, and the "and" was just meant to say that the definition of telehealth includes both of those things. So I think that the store and forward technology is I think that it falls within that definition, as I think that Mr. Young from Medicaid was talking about earlier. The second thing I will say is that NRS 629.515 does not authorize or prohibit anyone from engaging in any activity, depending on whether it's telehealth or not. Like, it doesn't say that if it's not telehealth, you can't do it. And it doesn't say that if it is telehealth, that you can do it. All it says is that if you're going to use telehealth for the purposes prescribed in subsection 1, you have to be licensed in this state. And the boards are allowed to regulate beyond that. And so basically, as I said, it's not that particular statute and that particular definition is not about what people are allowed to do or not allowed to do, with the one exception is that if you are doing the things described in subsection 1 through telehealth, you have to have a license. And that's the extent of it.
Okay, thank you. So I'll pause again and see if any members have questions. And Ms. Shalhagian, do you have anything to add?
Thank you, Chair Ratty. Actually, if you don't mind, I have our attorney, Mr. Greg Ott, on the line, who helped me review this and looked at the clarification of their intent, and if I can direct to him for his analysis.
Nothing more than I love is multiple attorneys with an opinion of a billing. So of course, Mr. Ott.
Deputy Attorney General Greg Ott, I will be brief, Chair. I don't have very much to add to what Mr. Robbins said. I was actually agreeing and nodding with my camera off, so I think he did a very good job. And I came to the same conclusion when I looked at the statute.
Okay. So generally, you're both saying that your belief is that it's broadly written, therefore it can be inclusive of anything, and that it really is only tied specifically to licensing.
Yes, that's what I would say.
Okay. Again, committee members? Anyone have any questions on this one? All right, then we are going to move to the amendment proposed by, I believe it's the ATA, and I'm looking for Kyle Zebley. So same format, Kyle, 3 minutes to present your support testimony and the amendment.
Thank you so much, Chair, and thank you so much to the committee. My name is Kyle Zebley, and I'm representing the American Telemedicine Association. Thank you for the opportunity to testify before you today. We applaud the work done by the legislature for their efforts to craft common sense telehealth policy. On behalf of the ATA and the over 400 organizations we represent, I am testifying in support of Senate Bill 5 and to offer additional amendments to further expand Nevadans' easy and efficient access to affordable quality healthcare. The ATA is supportive of the fact that if passed, this legislation would mandate that public and private insurance plans cover telehealth services. This would make it easier for Nevadans to access high quality, affordable healthcare in a cost-effective manner. The ATA does support amending the language to reflect a technology-neutral definition of telehealth that would specifically include asynchronous technologies. State legislatures should not discriminate against certain technologies so long as the licensed practitioner determines, in his or her professional opinion, that the technologies used in the delivery of telehealth services are sufficient to diagnose and or treat the condition presented by the patient. Additionally, the ATA recommends supporting Teledoc's amendment just mentioned that would include language that would allow a physician-patient relationship to be established via the use of telehealth technologies if such a relationship does not already exist. The ATA maintains that so long as the patient has consented to the use of telehealth, it is an acceptable mode of delivering healthcare services, and the patient and practitioner have identified themselves and disclosed the appropriate credentials. A practitioner and patient should not be prevented from establishing a professional relationship through the appropriate technologies that meet the standards of care. For licensees, having codified permission to establish physician-patient relationships via telehealth would make practitioners more comfortable doing so. Lastly, I'm proclaiming the, of course, support for allowing peer-to-peer consultations via telehealth. Peer-to-peer consultations do not involve diagnoses or treatments. They simply enable patients to access the opinions of licensed experts around the country, regardless of those experts' geographic locations. Nevada is currently one of only 11 states which has yet to adopt a statute that allows for peer-to-peer consultation through telehealth technologies between a state licensed practitioner and an out-of-state medical expert, without that expert having to be licensed in both locations. All of Nevada's neighboring states, with the exception of Utah, allow for peer-to-peer consultations via telehealth. Including this language would bring Nevada in line with the rest of the country and build this progressive telehealth policy we have been talking about today. Thank you so much for your time, and let us know how the ATA can be helpful in your efforts, and happy to answer questions.
Yeah. So some similar concepts here. Let's start with the peer-to-peer notion that it's not explicitly covered in state law, and the establishing the patient relationship pieces. So, Mr. Robbins, I think you've seen the amendment. Is there any concerns about the language suggestion around peer-to-peer? We'll start there.
No, that would be something that we could include. It wouldn't be legally problematic. It would just basically restrict the ability of the professional licensing boards to regulate these sort of consultations.
And is that same thing true in terms of establishing a patient relationship via telehealth? Is it now currently required that that be done in person?
That is up to the individual boards that regulate the various healthcare professions. So, I'm not really sure what sort of requirements they have, but it's up to their regulations and their standards of practice.
Okay, so the notion of those two amendments is the legislature dictating that versus the boards regulating that.
Exactly.
Okay, great. Thank you for the clarification. I see that Dr. Hardy has his hand up. So Dr. Hardy.
Thank you, Madam Chair. I'm a little confused. The peer-to-peer consultations happen all the time now. Is the peer-to-peer also have a patient in the middle of the peer-to-peer, and therefore it can charge? The peer in the other state can charge, or the peer in the state of patient residence can charge? Or is it just allowing a peer to talk to a peer? I'm not sure what the peer-to-peer thing, peer-to-peer consultations happen all the time. What does this proposed amendment do any different than picking up the phone and talking to a specialist in Salt Lake City or in LA? What does that mean? The peer that is in Nevada can charge the patient's insurance or patient themselves, or the conversation that the doctor in Nevada has by talking to the doctor in Utah? Is that what we're talking about?
Mr. Zebley, do you want to answer that?
I don't believe this is in regards to reimbursement. It would just be the legislature making clear that it is an appropriate way to have telehealth interactions with another peer in another state. Senator Hardy, if that makes sense.
That doesn't make sense at all. We can pick up the phone, and have always been able to pick up the phone and talk to somebody at UCLA or University of Utah. Is that illegal now, and we're going to make it legal?
I think it would be making it. This is Kyle Zebley for the record. I think it'd be making it explicitly legal. I don't know if it is explicit at the moment, Senator Hardy. I don't believe it is.
So you've heard the concept of freedom of speech?
Yes, sir.
Okay. So I think asked and answered. Thank you, Senator. Other questions on the concept of the amendment? Ms. Shalhagian, anything that you or that Mr. Ott would like to add to the conversation?
Senator Ratty, I don't have anything to add, and I'm not sure if Attorney Ott does either, but I would check in with him. Sorry.
I got nothing to add.
Okay.
Okay. All right. So thank you, Mr. Zebley, for your time here today.
Thank you
All
so
right.
much.
So is there anybody else who is in the Zoom call who is here to testify in support? We would be moving beyond folks who have an amendment now and just looking for folks who are on the Zoom call who are intending to testify in support. Don't believe there is, but I'm just double checking. All right, BPS, then if you could go ahead and open up the phone line for testimony in support of SB 5.
Thank you, Chair. Callers, if you'd like to testify in support of Senate Bill 5, please press *9 now to enter your place in the queue. Will the caller with the last 3 digits of 074 please slowly state and spell your name for the record? You will have 3 minutes and you may begin now.
Thank you. Madam Chair and members of the committee, for the record, my name is Charlie Shepard, CharlieShepard, and I am the state president of AARP Nevada. We have certainly seen the value of telehealth during the pandemic for improving access to medical care and treatment. When people are basically told to stay home as much as possible, telehealth may be the only option available for medical appointments and services. SB 5 makes an important addition to the availability of telehealth for Nevadans. By allowing the use of standard telephones with audio only, this will greatly help many Nevada families. Many low-income Nevadans lack the means to have access to video, and they rely just on standard telephone. Many older Nevadans still rely on that old trusty standard telephone that plugs into the wall and do not have cell phones with cameras or video capability. These groups should be able to have access to telehealth services using the equipment they currently have and can afford. The data dashboard is another important addition that will help us determine how telehealth is being used, by who, and best practices. However, in Section 1, subsection 1A2, age is a critical category that must also be indicated as, open quote, another category determined useful by the department, close quote. They should also consider family caregivers' involvement as another useful category. During this time of COVID-19, people have been told to stay at home as much as possible. And we also know that transportation is also a huge barrier for many older Nevadans and low income. Telehealth can bring routine and specialty health services to their home when trips are challenging, or perhaps may even be dangerous. In addition, there are 350,000 family caregivers in Nevada who provide unpaid care to a friend or loved one, many of whom could benefit from broader access to telemedicine. Family caregivers need help if they are to continue doing what they do. And telemedicine is one way to provide this needed support. AARP, on behalf of our 345,000 members across the Silver State, support SB 5 that will improve access to health care by increasing the availability of telehealth for Nevada families who must rely on standard telephones with audio only. Thank you, Madam Chair.
Thank you. Let's go ahead and continue on with the next person in support. And I'm not sure that I said we're limiting testimony to 2 minutes.
All right, thank you, Chair. Will the caller with the last 3 digits of 261 please slowly state and spell your name for the record? You may begin now.
Good afternoon. For the record, my name is Jazz Margarita Tobin, T as in Tom, O, B as in boy, O, N as in Nancy. Thank you, Senate Committee on Health and Human Services. I am an organizer with Planned Parenthood Votes Nevada and a community member. Planned Parenthood Votes Nevada is in favor of SB 5 because making telehealth accessible through the standard telephone would be a long-term investment in the health, safety, and well-being of Nevadans. Not only does telemedicine help connect geographically isolated areas to vitally important healthcare, but it is also an essential tool to addressing the health disparities that exist for BIPOC, that's Black, Indigenous, people of color, rural, and medically underserved communities. In fact, the removal of restrictions and increased public and private coverage for telemedicine due to COVID-19 has allowed providers to see more patients safely and efficiently. This temporary expansion has provided a demonstration of what innovative, broadened access to telemedicine can do. Please support SB 5 and expand more equitable healthcare access for Nevadans. Thank you again, Chair.
Thank you. Next caller.
If there are any more callers that just joined us and wish to give testimony in support of SB 5, please press star 9 now to enter your place in the queue. Chair, at this time, there are no more callers wishing to testify in support of the bill.
Thank you. Let's go ahead and move on to opposition.
Absolutely. Callers, if you'd like to testify in opposition to Bill 5, please press star 9 now to enter your place in the queue. Once again, to testify in opposition to Senate Bill 5, please press star 9 now. Caller with the last 3 digits of 090, please slowly state and spell your name for the record. You will have 2 minutes and you may begin now.
Good afternoon, Chair Ratty and members of the committee. For the record, this is Chelsea Capurro here on behalf of the Health Services Coalition. We are a group of union and employer self-funded health trusts. We have 25 members and represent almost 300,000 lives in Southern Nevada. We think this bill has a lot of really great pieces to it. Telehealth, as I think everyone has come to realize, especially during this pandemic, has great resources and really supportive of the general concept. We're also really supportive of the data dashboard and think it's a great service for all of our members. We do have some concerns about the pay parity piece in this, so that's why we're here in opposition. We do have opposition to that piece, but overall generally support the concept of this bill.
Thank you.
Will the next caller with the last 3 digits of 835 please slowly state and spell your name for the record? You'll have 2 minutes and you may begin now.
Thank you, Madam Chair. Dalton Hooks, DALTONHOOKS, with the law firm of Hooks, Mang and Clement, here on behalf of the Nevada Self-Insurers Association, speaking in opposition to SB 5 as written. Our members are specifically concerned about the impact that audio-only and other asynchronous modalities for the provision of medical services will have on the workers' compensation system. Section 7, which modifies NRS 616C 730, and Section 9, which redefined the definition of telehealth as contained in NRS 629515, are particularly concerning for our members. Workers' compensation is not the same as general lines of health insurance, and the Nevada Industrial Insurance Act and its grand bargain represent a careful balancing of the interests of multiple parties, including employers, insurers, third-party administrators, and the injured workers. The initiation of a claim under the Nevada Industrial Insurance Act involves reporting of potential workplace injury to your employer and then seeking appropriate medical care. This involves a careful assessment by a medical professional who would, of necessity, need to see injuries and signs of an illness, because over and above just finding a diagnosis, they are charged under the Act with opining as to whether, upon their examination or what they're told by the allegedly injured worker, they can, quote, directly connect the injury or occupational disease as being job incurred. So this is not the same as a doctor in private practice as outlined by the representative from the ATA. Specifically, we are concerned about secondary gain and fraud issues, identity verification, malingering, which could be obscured, the lack of nonverbal observations and tactile testing, increased in complexity in the system, and a lack of an adequate definition under NRS 629515 to include, for example, which modalities could be done via telehealth. So for these reasons, we must oppose SB 5 in its current form. Thank you, Madam Chair.
Thank you. Next caller.
All right, well, the next caller with the last three digits of 523, please slowly state and spell your name for the record. You'll have 2 minutes, and you may begin now.
Thank you, Madam Chair, members of the committee. My name is Tom Clark, T-O-M-C-L-A-R-K. I'm here on behalf of the Nevada Association of Health Plans on Senate Bill 5. And we recognize all the great work that's been done by the legislature in 2013 and 2015, and also the work of the PPC over the last year, but we do have some concerns with Senate Bill 5. We recommend that insurers continue to have the flexibility to negotiate prices to keep health coverage affordable for the consumer. Services provided by telehealth must be comparable to the services provided in an office visit. Insurers and providers must be able to establish different reimbursement rates based on the clinical effectiveness and intensity of the visits. It's important that we can develop value-based arrangements by focusing health outcomes, not just the volume of services provided. The payment parity provision is contradictory to telehealth's cost effectiveness. If telehealth can help reduce costs by using the healthcare system and reduce provider visits, it's contradictory to mandate that those services be paid at the same rate. Thank you, Madam Chair.
Thank you. Anybody else on the call? PPS?
Callers, if you'd like to testify in opposition and are just now joining us, please press *9 now to enter your place in the queue. Once again, if you are just now joining us and wish to testify in opposition to SB 5, please press *9 now. Chair, at this time, it appears no more callers are wishing to testify in opposition to Senate Bill 5.
Thank you for that, BPS. Okay, we're going to come back to the Zoom call and move to neutral. And I'm going to ask Kyra Morgan to step up and present your neutral testimony and the amendment you've suggested.
For the record, this is Debbie Reynolds, Deputy Administrator with Public and Behavioral Health. I believe Kyra Morgan got kicked out of Zoom and she's trying to reconnect now. I do apologize. I may be able to present the amendment. The proposed amendment that was put forward by the Department of Health and Human Services allows us to collect and report on the data that's currently available to us. The bill as written does not refer to the data that is only available to us at this time. So we understood it to mean that we would need to reach out and collect the data, which is why there was currently such a large fiscal note on it. However, the amendment as proposed would allow us to remove our fiscal note.
Thank you. And that's in line with the testimony on the bill that this was intended to collect existing data and share it. Okay. Any members of the committee, any questions specifically to the amendment? And Senator Hardy, your electronic hand is still up, so I'm not sure if that's a holdover from the last conversation or if you have a question.
Oh, I always have a question. Thank you, Madam Chair.
Right. Specific to the amendment.
Well, let me ask the question, which amendment? Because I've heard somebody talk about a provider talking to a family member. And so I'm totally confused because where I come from, we're talking about telehealth being used in order to be able to have payment, because we talk about payment parity, but the bill, the
Senator Hardy, if I could just interrupt for a second. So the teledoc and ATA amendments were addressed under support, and I think you had your questions answered there. At this point in time in the hearing, we're focused on the amendment from DHHS that is really just about saying whatever data is available and whatever funding is available, then they're going to do the data dashboard piece. I'd like to keep us on that in this neutral testimony. When we finish testimony, we will bring it back to the sponsor, and if you have additional questions, I will give you the opportunity to ask questions there. Does that work for you?
Yep, thanks.
Fantastic. Senator Harris, you also have an electronic hand up. Is that for the DHHS amendment?
It is. Thank you, Chair Ratty. So I understand that, we've made it clear we're going to be using data that we're already collecting, and so there's no additional expense there. But I imagine the creation of the dashboard itself is still going to cost something. Is that right?
So this is Kyra Morgan, for the record, state biostatistician for the Department of Health and Human Services. We actually believe with our current staff and software solutions, we can probably build the dashboard out using existing resources.
All right, fantastic. Teach other agencies how to do that. That'd be great. Thanks.
Thank you. And again, Ms. Morgan, just because I think it's important that this is on the record, your colleagues testified that this amendment would remove the fiscal note. Is that your assessment as well?
That's correct. I apologize. I'm having connection issues. I'm sorry. The amendment really just clarifies the language that I think Sarah talked about at the beginning to strengthen it, to ensure that we're not relying on additional data collection, that we would be using the data and resources that are already available to create the dashboard, which would eliminate the fiscal note from the Division of Public and Behavioral Health.
Great. We're just going to sail past the irony that the data person is having connection issues on the data and telehealth bill. All right.
Thank you.
Let's go ahead and see if there is anybody. Doesn't look like there's any additional questions from the committee specific to this amendment. All right. BPS, if you could open up the line for any additional testimony in neutral.
Thank you, Chair. Callers, if you'd like to give a neutral testimony for Senate Bill 5, please press *9 now to enter your place in the queue. Once again, *9 now for a neutral testimony on Senate Bill 5. Will the caller with the last 3 digits of 500 please slowly state and spell your name for the record? You'll have 2 minutes, and you may begin now.
Hi, good afternoon. This is Helen Foley, Helen, F as in Frank, Oley, and today I am representing Delta Dental. And we are calling in support of the DHHS amendment because we believe that the language, to the extent resources and data are available, satisfies our needs and concerns. As we first looked at the legislation, I must say that Delta Dental does support telehealth and has been working closely throughout the United States on these issues. But when we saw that there might be some very specific intrusive questions that, if someone comes into a dentist's office and they need a tooth filled and they're asked what their gender identity is, and their sexual orientation and whether they have mental health problems, we just did not feel that was appropriate. But now with this new amendment, so that it just includes data that is already available, we do not have an objection to the legislation. And thank you for your time.
Thank you. EPS, anybody else in neutral?
Chair, at this time, there are no more callers wishing to give a neutral testimony for the bill.
Okay, I appreciate that. We're going to take this hearing back to the bill sponsor, the Patient Protection Commission, and Ms. Shalhagian, if you would like to make any closing remarks, and then we'll make sure that all of the committee members have their questions answered.
Thank you, Chair Ratty, Sarah Shalhagian, for the record. I just would like to say in my closing remarks that I thank you for your consideration of this measure and really want to thank everybody who is a part of the process in helping to address clarification of the intent. And I would be remiss if I didn't pause and thank each and every one of the commissioners who put in the effort and the time and the work to put this measure in front of you.
All right, so committee members, working real hard here in a virtual environment to not have this turn into a free-for-all, but I do know that we have a bill that was presented by the sponsor with 3 amendments. My top concern here is that you get your questions answered. So if you could just be very clear about who you're pointing the question to and what topic, I think that would be helpful. So any additional, Senator Hardy, I believe you had questions. I'll start with you.
Thank you, Madam Chair. So let me clarify for my own edification. This has nothing to do with preventing a doctor from talking to a doctor someplace elsewhere, nor does it have anything to do with getting payment for that, nor does it allow or not allow a doctor from talking to another patient's family or a family caregiver, nor does it allow payment for that interchange because it's already going on. And even though it's not explicitly allowed, it's what we do anyway. And this bill doesn't change that at all, nor does it reimburse for that.
Ms. Shalhagian, do you want to answer that as the original bill?
Sure. Thank you for the question, Senator Hardy. Sarah Shalhagian, for the record, I believe that is correct, Senator Hardy, as the bill is written. I do think that maybe there's questions related to one of the proposed amendments that seeks to modify that, Senator Chair Batty.
Yeah, and just going to check in with Mr. Ott. Is that your understanding of the bill as written as well?
Gregory Ott, yes, that is my understanding as well.
Okay. So then there's the amendment, and help me out, Ms. Kamlasi. So the original amendment, is the peer-to-peer piece in both the ATA and the Teledoc amendment, or is it just in the ATA amendment?
It is definitely in the ATA amendment. And give me 1 second. It is. It's also in the Teledoc amendment.
All right. So, hold on, I'm going to get this right. Sorry. Too many things going on. Ms. Tucker, would you like to address the peer-to-peer question and why you believe it's a concern and what your amendment seeks to do? Well, it looks like we may not have Ms. Tucker anymore. All right, so it looks like we actually don't have the presenter of the amendments anymore for either one. So I'm going to go to our legal counsel, Mr. Robbins. What can you talk to us at all about what current law is in terms of the peer-to-peer interaction and if this amendment would have an effect?
Well, under current law, as I said before, it's kind of up to the individual, what's allowed under the individual statutes and regulations governing the different professions. But for physicians in particular, NRS 630.047 subsection 1 paragraph B basically says that a physician doesn't have to have a license if they are if they're consulting with or providing assistance to a Nevada licensed physician, and they're legally qualified to practice in the state where they reside. And that statute doesn't explicitly mention telehealth, but generally where telehealth isn't explicitly made different, we interpret the same provisions that apply to the provision of services in person to apply to the provision of those services by telehealth. So consultation on an irregular basis for physicians is explicitly allowed by Chapter 630.
Explicitly allowed.
Yes, explicitly authorized.
Senator Hardy, does that satisfy your question?
Yes, and this doesn't change that. As I read it, it does nothing to change it, nor does it allow somebody to charge for it in a payment parity, nor does it prevent me or any other physician from talking to a family member who's a caregiver.
Correct. I think the testimony from the folks who were seeking the amendment was they were looking for it to be more explicit, but the testimony from our attorney is that it's already allowed.
Thank you.
Okay. Any other questions for the bill sponsor? All right. With that, then I'm going to go ahead and close the hearing on SB 5. And we're going to open the hearing on SB 40. Ms. Shalhagian. I think I have pronounced your name like 15 different ways on this particular hearing.
Thank you, Chair Ratty. If you can, just give me a second, I'll share my screen.
Take your time.
Okay, thank you, Chair Ratty, members of the committee. My name is Sarah Shalhagian. For the record, I serve as the Executive Director of Nevada's Patient Protection Commission. So earlier in my hearing on SB 5, I gave you an overview of the commission, their meetings, activities, and ultimately what led to the last measure that is applicable to this measure. So it was in the same hearing and work session on the 31st. That the commission discussed, debated, and voted on their working document, which is going to be putting this measure in front of you. So I'm going to skip to that and being mindful of everybody's time this evening. So Senate Bill 40 is in front of you today, and the intent of this measure is a bill that seeks to enact mandated reporting of data to the State of Nevada Patient Protection Commission, Department of Health and Human Services, the Attorney General's Office, to allow for the monitoring of the healthcare industry, including pricing for healthcare components, all healthcare insurers, all payer claims, drug costs, hospital prices, healthcare entity ownership and mergers, consolidation, closures, and governance for healthcare committee. Specifically, I'll go back one second. This is another measure that really seeks to improve access to care, but again, with the same mindset of that you can improve what you can't measure. So this is the first step to address monitoring of the healthcare industry and looking at healthcare costs. Specifically, the request, as agreed upon by the commission, does 5 things that I'd like to touch upon. The first one is it requires an inventory of the currently reported health data in Nevada that can be used to analyze trends, costs, prices, consolidation, and patient access to care. Chair Ratty, I do not anticipate going line by line, but I would like to highlight the sections that each one of these requests have and set it up for questions by the committee. This particular request relates to Section 20 of the bill. The second part of this request is it requires a report each year summarizing healthcare quality in Nevada for presentation to the governor, legislature, and the commission. And that is addressed in Section 14 of the bill. The third component is it ensures that the commission and the Department of Health and Human Services has the authority to request ad hoc reports regarding price, cost, consolidation, and access to care. You'll find that in Section 1. The largest portion of this measure relates to the establishment of an all-payer claims database. But before I go into that, I really want to take a moment to highlight Senator Spearman's work on paving the way for this conversation to happen. In the last legislative session, she had a measure that sought to establish an all-payer claims database. And as the commission was deliberating and debating on this measure and transparency measures, I communicated with her and told her that the commission was deliberating this, and she was quite enthusiastic to see the conversation be picked up. So I'd like to just pause and recognize her efforts for paving the way for this measure. The database requires the Department of Health and Human Services to establish an all-payer claims database of information relating to health insurance claims resulting from medical, dental, or pharmacy benefits provided to the state. Public and private insurers that provide health benefits are regulated under the state must submit data to the database, and certain insurers regulated by federal law may submit data to the database. Section 9 is the primary authorizing legislation, and all other sections relate to the establishment of this database. And finally, this measure mandates reporting of data to the state of Nevada, to the PPC, Department of Health and Human Services, the Attorney General's Office, to further allow for the monitoring of the healthcare industry. And there are provisions in Section 1 and 13. And now I'm ready to answer any questions that you may have, and I suspect there may be a decent amount.
Okay. Senator Harris, would you like to start with what I suspect might be a similar line of questioning?
I would. Thank you, Chair Ratty. So my question is data protection. I'm guessing, and of course, HIPAA will continue to be the standard for all health information, but who will have access to this database? Who will be able to kind of ping that information on, I guess the individual level? And what type of protections or parameters do we anticipate being put around that access?
Thank you so much for the question, Senator Harris. Sarah Shalhagian for the record. I can tell you that this legislation primarily focuses, as it's written, on authorizing the state to create the data dashboard and establishing regulations for that creation to include the data collection process, the data release process. But what I would like to do is defer to Sandy Rublet, who is on the line, who can answer questions you have. She's the Chief IT Manager and pretty much the guru of the all-payer claims database efforts for our state. So if you don't mind, Chair Ratty, I really would like to lean on her to help answer some questions Senator Harris has likely around the regulatory process.
Go ahead.
Hi, so this is Sandy Rublet. I'm the Chief IT Manager for the Department of Health and Human Services. To answer the first question, which I believe was about security requirements, what we would do is contract with a third-party vendor, and part of that contracting process would require that they have certain certifications, and there's a lot of acronyms here, so bear with me. The first one is the Health Information Trust Alliance, or High Trust certification, and that ensures that they would comply with HIPAA regulations, in addition to the National Institute of Standards and Technology, or the NIST security requirements. So that's about protecting the data that we would house, both in transit, stored, and in release of the data. So we would follow those HIPAA requirements for that. As far as releasing the data, for the most part, it would be de-identified and aggregated. It wouldn't be, someone able to ping the database for one particular patient. But, and I would defer to Kyra to explain a little bit more about the data requests in detail, but there is a situation where we would release data in an identified manner for research purposes, and those would be governed and controlled with data use agreements between the parties to ensure that there's an agreement and liability to ensure that data is not released improperly. Hopefully that answers your question, Senator Harris.
And this is, sorry, this is Kyra Morgan for the record. I'm the state biostatistician of the department.
All right, I think we may have lost
Department of
you.
Health and Human Services. I'm sorry.
Ms. Morgan, I think we may have lost you again, but give it a shot now.
I would just add that we're already collecting all of this information on our Medicaid population. And so the security protocols that we have in place to protect that information would be extended to this population. We also collect highly sensitive data around our communicable diseases, including things like HIV, where we obviously have to maintain confidentiality to the highest regard. And so we do have a lot of processes in place to protect this information. This would really just be an extension of that to include payers that aren't already captured in some of our already existing data collection mechanisms.
Thank you.
Other questions? Senator Hardy.
Thank you, Madam Chair. I have grave misgivings about Section 5, which indicates a patient with all the other identification things, knowing that banks are hacked, Eater is hacked, the state is hacked. They haven't made an unhackable situation yet. So this one takes an individual name, the social security number, the telephone number, the medical record number, the health plan beneficiary number, the license number, the vehicle identification number, the serial number, the internet address, the electronic mail, the biometric identifier, and a photographic image. I mean, that's a recipe for disaster when someone hacks it. I have major misgivings about this. Thank you. I guess it's more a statement than a question. Thank you.
Ms. Shalhagian, any comment?
Thank you, Senator Hardy, for your comments. I can tell you that this specific language was not included in the Commission's request, and it was more of a product of drafting interpretation and indicating that it was a necessary component of this measure. And if you would like to have more comments about this, maybe Sandy could opine on her thoughts on this, but I'm not sure that is what you're seeking.
So let me just make sure that we're understanding the flow of the bill, and so we may need Mr. Robbins' help on this, but I think that this is the information that they're specifically saying can't be released individually and must be aggregated, correct? So it's the list of things we want to protect.
Hello?
Yep.
Okay. So, yeah, this is just the definition of the term direct patient identifier. It's not saying that that information is going to necessarily be included in the all payer claims database. It's just saying that if any of that information does wind up in the all payer claims database, then it has to be treated in a certain manner under Section 13, and basically the people who can have access to that information are very, very limited, especially with respect to the other types of information that may be in the database.
So again, doesn't direct the AP. That information says that if any of that information makes it into the APCD, must be protected, can't be. That is the individual identifying information we're protecting.
Yes.
Okay, thank you. Senator Hardy, additional questions?
I think it's very optimistic. Thank you.
Senator Spearman?
Thank you, Madam Chair. And I think when we had this session, there were some concerns around that as well, but if I'm not mistaken, I think Washington State has something very similar. And I know that they have increased security. I mean, nothing's 100%, but they've increased the SSL security on this type of information. And for the most part, if I'm not mistaken, I think a lot of it is redacted so that other than research or trying to establish what the patterns are, I don't know that there's identifiable information on a person. I could be wrong though, but I think some of the protections are in redaction and making sure that when it is disaggregated, that there's no compartmented information that will allow someone to go back and identify an individual. I think so.
Thank you, Senator Spearman. So Ms. Shalhagian, perhaps since there has been some time that has passed since we looked at this concept 2 years ago, you could talk about the number of states who have APCDs now and what's happening on the federal level around APCDs.
Thank you, Chair Ratty. Senator Sarah Shalhagian, for the record. I am aware of, I believe, 19 states that have established all-payer claims database, and there is a national effort under the No Surprises Act to entice other states to create all-payer claims databases, and it provides an opportunity for federal funding. And I believe it's a non-competitive application process, but I am not the expert, and I would like to defer to Sandy, who knows a lot more than I do about the federal grant process, and she's monitoring that as well as what other states are doing.
Thank you. Just a reminder to reintroduce yourself for the record.
Yes. Thank you, Sarah. This is Sandy Rublet. I'm the Chief IT Manager for the Department of Health and Human Services. Sarah's correct. There are around 19 to 23 databases in existence in varying sizes. I think the first one established was in Maine, and there is a lot of interest at the federal level, so much so that there is a non-competitive grant for all states to apply for. We believe that the funding would be available starting in October, and we do intend to apply for that grant. There is $2.5 million available over a 2.5-year period to either improve your existing or establish an APCD. So we are very interested in that.
Thank you. And then, Ms. Rublet, while you're here, perhaps you could talk about the data that you see and what data is typically collected in an APCD.
Thank you for the question, Senator Ratty. Sandy Rublet for the record. Typically, at the base level, it's claims data. So what would be included in a normal standard claims transaction is what is typically included in an all-payers claims database. Some states have decided to have other feeds into the database to help enrich their data, but at the very minimum, it is claims data. So I wouldn't necessarily think that we would find a vehicle identification number or biometric information as described in that description in Section 5, I believe. But I'm sure maybe some other states have done that. Maybe they have connections and needs for that data.
The intent of this legislation is claims data. So we're talking about the patient, what the patient condition was, what got billed, what got paid for. And just, I think, a reminder that the point of this bill is for us to understand how much healthcare costs so that we can start to make informed decisions about how we invest our dollars in terms of healthcare and how we manage healthcare costs. That's what we're after here.
Correct. That is exactly what we're after. Sandy Rublet for the record.
Other questions from the committee? Senator Hardy.
Thank you, Madam Chair. Going back to the prior bill, with the Social Security number, I suspect they can figure out age. So the comment that was made about age apparently isn't in this, and question mark. And then have any of these 19 or 23 states have a data breach from their database ever yet?
Thank you for the question, Senator Hardy. This is Sandy Rublet with the Department of Health and Human Services. I am not aware of any data breaches in an all payers claims database. Because of the nature of the data that is housed in the databases, it is very, very important that we focus on security and privacy of that information. So there are very strict standards in place for the technology and the behavior of anybody who is housing that data.
And again, would a social security number typically be in a insurance claim?
Not Sandy Rublet, for the record, not generally, no. We would not want to collect data that isn't necessary just because of the risk.
Additional questions? Senator Kieckhofer?
Thank you, Madam Chair. Back to, I think, 2011, but I worked quite a bit at the time on the State Health Information Exchange, and we talked a lot about an individual patient's ability to make decisions about whether they wanted their information uploaded into a government-run system. The way I read this, right, is that basically you can't have private insurance or public insurance, for that matter, without having your health care claims submitted to this payer database, right? Is there an opt-out?
Thank you for the question, Senator Kieckhofer. Sandy Rublet, for the record. I have seen other states' legislation include opt-out language. Again, the data that we would publicly publish it would be aggregated data. It would not have any unique patient identifiers. I believe the only time that direct patient identifiers would be released would be in the case of researchers requesting data, and we would have strict data use agreements in place. But I have seen other states have opt-out language for that, of identifiable data, sorry.
So, I mean, look, I understand that, we try to protect it as best we can. But when we hold it and we hold it all in one place, it becomes a target, right? So, I think I share Dr. Hardy's concerns about me as an individual who's, potentially required to carry health insurance, right? And then have the data collected by that health insurance company as a part of their payment system be required to be turned over to the government analysis. Maybe that's more of a philosophical statement than a question, Madam Chair, but I'll leave it at that. Thank you.
And a lot of that going around in this hearing, including myself. So we'll try to see if there are any more clarifying questions on this particular bill. We also do have amendments, so there's going to be more opportunity, to learn. All right, so then we're going to go ahead and open this hearing up to folks who have amendments on the call who would like to testify in support. So if you could turn your cameras on and let us know if you are here. Assure. All right, so I'm going to call on Assure. Is it Lysick? Sorry.
Yeah, Assure Lysick from Pharma for the record. Madam Chair, members of the committee, thank you for the opportunity to speak with you all today. Pharma is in support in general to an all-payer claims database bill. We think this will help highlight the cost drivers in the state of Nevada and really provide that important Nevada-specific information on healthcare costs in the state. We have submitted two clarifying amendments that are available as exhibits on the website. The first relates to the definition of proprietary financial information in section 7, recognizing that healthcare agreement can occur between more parties than just healthcare providers. We have asked that proprietary financial information in an agreement between a manufacturer of a prescription drug also fall under the definition of proprietary financial information. The second amendment is to section 20 of the bill, and it is to add if there is a report that is released and it is available, that the report consider race, ethnicity, and other health disparities. We think this is an important area for the state to consider, especially given the pandemic and the inequities that we have seen in healthcare. Just to clarify with that amendment in Section 20, it would not require the department to collect any additional information. It would be more to Senator Ratty's point on SB 5, where if you can determine information based on neighborhood or zip code, consider that in the report potentially for further investigation or otherwise. Also, just while I'm testifying in support, we've reviewed amendments by others and just want to flag that PhRMA has some concerns with the amendment offered by the Attorney General's office in Section 1, Number 2, and I'm happy to continue to work with stakeholders to address those concerns and hopefully see the passage of SB 40. Thank you.
Thank you. Is there anybody else on the call who is testifying in the support that is here to present an amendment? I have amendments from a group of stakeholders and Carfax, but I don't know that they're under support. Check in my gallery. Okay. Mr. Clark, can you confirm, is yours going to be more an opposition or neutral?
Thank you, Madam Chair. Tom Clark on behalf of the Nevada Association of Health Plans. Actually, Bill Welch and I were going to testify in support with a conceptual amendment that we've presented.
Fantastic. So please proceed. And for the members of the committee, this is the conceptual amendment dated March 8th, 2021, and it has the 4 sponsors across the top: Nevada Association of Health Plans, Nevada Hospital Association, Nevada State Medical Association, and PCMA. You have 3 minutes to provide your support testimony and discuss the amendment. Mr. Clark.
Thank you, Madam Chair and members of the committee. My name is Tom Clark. I'm here on behalf of the Nevada Association of Health Plans. As the chair referred, we're speaking to a conceptual amendment that was worked on with the 4 groups that are listed. Myself and Bill Welch will each kind of tag team some of this, and we'll get through it as quickly as we can. Jumping straight to the amendment, and first of all, I do want to say that we firmly believe that the APCD is going to be a tool for public policy that's going to benefit Nevada long term. We support Senate Bill 40, and we simply want to make it robust and accurate and as quantitative as we possibly can. Mr. Welch will discuss Section 8 with the definitions. Going to Section 9, in subsection 1, this goes to Senator Hardy's question about data. Yes, there are certain things listed in Section 5 of the bill, but we firmly believe after conversations among ourselves and with other stakeholders that these will be determined in regulation. The other part that we would like to add in that Section 9 is some language that says that that the APCD will be built and maintained by a third-party vendor. In discussions, that may be already considered. So it may not have to happen in the legislation, but we would definitely want to make sure that a third-party vendor is acquired to do so. Mr. Welch will talk about Section 3. I'll jump to Section 10. Under health carrier in the definition, there's a couple of things that we'd like to not have to report to the APCD. Those carriers that provide Medicare supplemental insurance, dental, vision, and disease-specific insurance. And that's a pretty consistent theme throughout the other 19 states that have adopted these. And then also health carriers with less than 1,000 lives being covered, they would not be required to report under the APCD as well. Mr. Welch will touch on Section 11, jumping to Section 13. This really gets to when is all of this going to start, right? The timeline for the promulgation of the regulation, getting all of the stakeholders together and things, we're not really sure how long that's going to take. But what we would like the timeline to be for the collection and the release of data 6 months after the finalization of the regulations that create the APCD, that's when the clock starts. That's when we're all going to be participating in this process. Just quickly jumping down to Section 14, as far as the annual report is considered, we contemplate 2 committees that Mr. Welch will discuss. We hope that those 2 committees will be able to review that report before it's published. And then Section 17, there's 3 different places where money comes into play, right? The fee that you're going to charge for people to access the data. It's not in the legislation, but we foresee through regulation putting together a penalty phase for those insurers that are required to participate but do not. We really want this data to be as accurate and as quantitative as possible. And then the third part of that is that any of the monies that are collected from fees and or penalties would go directly into furthering the APCD and not the general fund. So Mr. Welch, if you're available, I'll turn it over to you.
Thank you,
Just
Madam
for
Chair.
the record, Mr. Welch, before you jump in, just for the record, I'll just remind everybody and more for the secretaries that we're still in support. And so again, 3 minutes to address support and the details of the amendment.
Thank you, Madam Chair and committee members. Bill Welch with the Nevada Hospital Association. I won't repeat Mr. Clark's comments, but we are here in support of the bill, and the committee coalition does support the intent of this legislation. I think it will be beneficial to the state of Nevada. Section 8, and we designated Section 8, but we really mean in the definition categories. There are terms used throughout the bill that we feel it would be beneficial to define so that there's clarity on what information is being collected, who is making decisions for research, and what is a government entity. So, for example, under cost of health care, depending upon who you talk to, you'll get a different interpretation of cost. And so we're proposing some definition in there is that cost of the provider to provide the service, cost of the payer to facilitate the insurance and pay for services, cost of the consumer for what their insurance cost is and what may be their out-of-pocket cost for services that they receive. With regards to research, we think it's very important that there's a consistency standard and guidance on what will be recognized as valid research, and that it does refer to an institutional review board. There is a federal definition for that, and we would suggest some language be in there defining who and what the institutional review board would be. Governmental entity, again, we could not find a standard definition in the NRS or in the NACs as to what is a governmental entity, and we think that there should be some parameters to lay that out because there's a lot of conversation or a lot of language in the bill that refers to releasing information to governmental agencies. Under Section 9, subsection 3, we do believe, and this is not, and I want to be candid, this does not happen in every state that has an APCD, but in our experience with the many hospital systems that we have in the states where they are working with APCDs, where they have found it to be most successful in accomplishing its goals, they have developed a stakeholders advisory committee to work with the state oversight regulatory body. This advisory committee is made up of key stakeholders of all of the components that would drive the APCD. This would help ensure proactive engagement and buy-in by all concerned parties. And then there's a data governance committee. The data governance committee would be made up by individuals within the organizations whose data is being reported and who is reporting that data so that we make sure that there's consistency in the platform and in the manner in which that data is being submitted so that there is the ability to bring it together and do the analytic work that is intended and be able to be aggregated for the release in reports. In Section 11, we do recognize, and there's been a lot of talk about HIPAA and the requirement for patient privacy, and we do understand that in the bill it talks about the state agencies that they will comply with that, but as has been demonstrated in the testimony today, this data can be released to researchers in its de-aggregated form for their research project. And I did hear one of the testifiers that they would put this in a participating agreement or the agreements with the researchers, but we think that there might be some value to strengthen that by saying in the legislation that in fact would be a requirement that any researcher accessing this data would have to comply with HIPAA as well. We do think that this, and we want to also, with regards to the aggregation and the release of this information, we know that that would apply to the various state agencies and as has been described today, but we think that there should be language in there that all researchers who access this data, any reports that they produce also must be released in an aggregated form so that there is no potential risk of compromising patient privacy and that there would also not be any risk of releasing any proprietary financial information from those data who's been reported. Section 12, we think that all reports that are produced should be released to the public. We also believe that understanding that the law can only regulate a small percentage of those who are insured in the state of Nevada, and while the law does provide for voluntary participation by self-funded plans, state plans, etc., they are not governed and are not mandated to participate. So we think in any report that's released, there should be some clarification of what % of the total population that this report really represents, so that we understand that it's, for example, what we believe is that about 19 to 22% of the insured lives in the state of Nevada are through commercially licensed insurance companies in the state of Nevada, who would be required to submit this information. And so you can see that the larger portion of insured lives would not be included in this data collection, at least unless they are voluntarily doing so.
Mr. Welch, we're getting close to 3 minutes. Are you getting close?
I'm done. Thank you, Madam Chair.
Perfect. Thank you. All right. So we also had amendments from Carfax and Quest Diagnosis, but I don't see anybody in the call. We might get them when we open up the phone line. And then we had another amendment from the AG's office, Mark Kruger, but Mr. Kruger, my suspicion is that you will be testifying in neutral. Is that correct?
That's correct, Chair.
Okay, great. So I believe that that's everybody who's on the line who wanted to testify in support. So we're going to ask BPS to open up the phone lines for anybody else who would like to testify in support. I'm sorry, be explicit, testify in support of SB 40, and we'll make that a 2-minute limit.
Thank you, Chair. Callers, if you'd like to testify in support of Senate Bill 40, please press *9 now to enter your place in the queue. Will the caller with the last 3 digits of 900 please slowly state and spell your name for the record? You will have 2 minutes and may begin now. Once again, caller with the last 3 digits of 900, please slowly state and spell your name for the record. You'll have 2 minutes and may begin now. If you're muted, you can try pressing *6 on your phone to unmute yourself. All right, Chair, we'll circle back to this caller. We'll move on to the next one.
Please do.
Will the caller with the last 3 digits of 122 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Good afternoon, Chair Ratty, members of the committee. For the record, my name is Katie Ryan, K-A-T-I-E-R-Y-A-N, and I'm System Director of Nevada Government Relations for Dignity Health St. Rose Dominican. We are here today as an us-two in support of the conceptual amendment provided to the committee by the Nevada Hospital Association et al. We wanted to go on the record also in appreciation of Sarah Shalhagian from the PPC, Senator Ratty, and other stakeholders for continuing conversations around best practices in other states and making sure we can make this bill the best it can be. Thank you, and I'm available to answer any questions.
Thank you.
All right, will the next caller with the last three digits of 090, please slowly state and spell your name for the record. You'll have 2 minutes and may begin now.
Good afternoon, or good evening now for the record. Chelsea Capurro, that's Chelseea, last name Capurro, here on behalf of the Health Services Coalition, representing over almost 300,000 lives in Southern Nevada. Our coalition has consistently supported transparency in healthcare quality and pricing, including the prescription transparency bills from 2017, 2019, and surprise bills from last session. We definitely support the transparency provisions in this bill. We also support the intent of this bill to create the building blocks our state needs for future quality and price management in healthcare. However, the process of building an Apcd also requires transparency and must remain in the public sector if there is hope that groups that can opt in will actually ever do so. Any private management of the governance, the process, or the management of the data will reduce trust in the program, and it's our hope that whatever is created is something that our plans will want to support and opt into. I would also just note that we want to make sure that any HIPAA, anything in the Apcd is HIPAA compliant for our plans as well, and that should there be any sort of data breach, that our plans aren't responsible for that. Thank you.
All right, well, the next caller with the last three digits of 362, please slowly state and spell your name for the record. You'll have 2 minutes and may begin now. Once again, caller with the last three digits of 362. Please slowly state and spell your name for the record. You'll have 2 minutes and you may begin now. All right, Chair, we'll go ahead and circle back to that caller 2. Will the next caller, whose last three digits are 089, please slowly state and spell your name for the record. You'll have 2 minutes and may begin now.
Thank you. For the record, my name is Babette Bond. Chairman Ratty and Vice Chair Spearman and members of the Senate Health Committee. I hope you can hear me okay. By way of disclosure, I'm a member of the Nevada Patient Protection Commission. But I'm here today on behalf of the Culinary Health Fund. I'm the Director of Public Policy for the fund. The Culinary Health Fund supports the Patient Protection Commission, and in its current version, the bill that's been created for SB 40. We like the current version. The Culinary Health Fund covers 125,000 lives with comprehensive health benefits. We contract with our own network, and we care for our members, which are 60% members of non-white races and ethnicity. We operate 2 pharmacies that allow patients to fill prescriptions without a copay, and we operate a health center that saw 40,000 patients the year before COVID. We really appreciate the effort that's gone into creating this legislation and the journey the Apcd has already gone through. We support the legislation for 3 reasons. The current state of Nevada healthcare transparency is incomplete and behind many states. The second reason is it's an important vehicle to monitor and evaluate the healthcare system going forward. And the third is it's an important foundation for new models of price and quality management, such as the Nevada Award by the Peterson Millbank program that was just announced today. ERISA plans, as you said, are optional. They can participate by choice. And for that to happen, the product has to be transparent, and so is the process. We support the program being housed within the public health arena. And we've heard testimony today that we want to urge the committee to pass the bill that was created, not the bill as amended by the stakeholder amendments that we've heard about. Particularly, we strongly oppose legislation that would de-identify the elements needed in a database, such as the provider and the facility and the price paid for services or care. We need that information for the database to work. We also think that the database should span times. The amendment that we heard about today sounds like it wouldn't, and so we think trend is important so we want to make sure that's included. And we want to make sure the committees that are assigned are advisory only, and they are not in charge of deciding what data will be submitted in the end. So we appreciate the opportunity to testify. We think this enabling legislation has a long way to go in the regulatory process, but we really hope our ERISA groups will participate, and we support the program as it develops. Thank you.
Thank you. Next caller.
Thank you, Chair. Will the caller with the last 3 digits of 503 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Hello, my name is Chris Bosse. That's C-H-R-I-S, B as in boy, O-S-S-E, representing Renown Health for the record. I'm testifying in support of SB 40 with the conceptual amendments offered by the industry. First, I want to thank Chair Ratty for taking the time to meet with stakeholders to better understand the recommendations being made, and really want to appreciate the work of the Patient Protection Commission, the work that they went through to prioritize the implementation of an APCD in Nevada. With a number of key issues in front of them, they recognize the important impact that an APCD could have in Nevada. And it's in that spirit, honoring the intent of the PPC, that the industry stakeholder group came together to provide feedback on SB 40 to ensure best practices and lessons learned from other states were incorporated on the front end of our implementation. I won't repeat what the other recommendations that were provided and you have in writing, but we believe these recommendations that the industry has proposed will ensure successful implementation, operation, and meaningful use of the APCD as early as it can be recognized. I want to thank you for your time today.
Thank you. Next caller.
Will the caller with the last 3 digits of 900 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Broadcast Services, can you hear me now?
Yes, we can. Please proceed.
Great. Thank you very much. This is Dan Musgrove with Strategy 360, DANMUSGROVE, here today on behalf of the Valley Health System of Hospitals. I certainly don't want to be repetitive, Madam Chair. Thank you for the opportunity to testify in support. I would just want to go on record as supporting the conceptual amendment put together by the stakeholders led by Bill Welch and Tom Clark. I certainly echo the comments of Chris Bosse with Renown and Katie Ryan with Dignity. We want to look at the best practices of other states and want to make sure that we have the best bill that we possibly can, and that's why we support the amendment. Thank you for the opportunity to testify in support.
All right. Will the caller with the last 3 digits of 362 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Thank you, Madam Chair. My name is Katie Robbins, K-A-T-I-E-R-O-B-B-I-N-S, and I'm here on behalf of Planned Parenthood Votes Nevada. We would like to voice our support for SB 40. We believe that the ability for the Patient Protection Commission to create an all-payer claims database will be an important tool in identifying how we can improve care and costs for all Nevadans. Having a more holistic understanding of quality, efficiency, and cost of care is also a good step towards making healthcare more fair and equitable in Nevada, something we know is critically needed. Thank you.
All right, Chair, at this time, there are no more callers wishing to give testimony in support of SB 40.
All right, let's go ahead and move on to testimony in opposition.
If you'd like to give testimony in opposition to Senate Bill 40, please press star 9 now to enter your place in the queue. Once again, if you'd like to give testimony in opposition to Senate Bill 40, please press star 9 now to enter your place in the queue. Okay, Chair, at this time, it appears no callers wish to give testimony against Senate Bill 40 at this time.
Thank you. All right, we're going to move to neutral testimony, but we're going to bring it back to the Zoom meeting. And I'm going to call on Mark Kruger from the AG's office to testify in neutral as well as explain the amendment. You'll have 3 minutes.
Thank you. Oh, get my video started here. Thank you, Madam Chair. Mark Kruger for the record, Attorney General's Office, Chief Deputy Attorney General. I won't need to take 3 minutes. We submitted an amendment. The reason for the amendment is because there seems to be unintended consequences with capturing confidential investigations by the Attorney General's office. And with that, I'll take any questions.
Okay. I think that we had a question. Hold on, Mr. Kruger, you were briefer than I was expecting you to be, so give me a minute. I think if you could expand on the second piece of your amendment, we need some clarification there.
Madam Chair, Mark Kruger for the record. The second piece that's in section, the new section? Okay.
Section 13, I think.
Oh, 13? Sure. Basically what happens is, in particularly under our Unfair Trade Practices Act under NRS Chapter 598A, we conduct confidential investigations, and a lot of times we work with the FTC or the DOJ, or we're working underneath a court order, or with other states. And the unintended consequence of not exempting out the confidentiality of those investigations would basically put us at odds with our federal or state partners or a court in our ability to continue our investigations, which we already have under authority under 598A. By exempting us out from the reporting of information that we receive during those investigations, that would protect that information, allow us to conduct our investigation, and then if information becomes public at a later time, we have no objection to cooperating with the PPC and turning information over to the extent that we can.
So bottom line, you believe that there's some language in this bill that would prohibit activities that you are already doing?
The bill's, Madam Chair, Mark Kruger for the record, the bill's language won't prohibit us from doing the activities, but will make it impossible for us to do the activities with our federal or state partners. So in effect, it would act as a barrier from us being able to conduct our thorough investigations into antitrust, which would ironically thwart the exact reasons for the bill and the intent to take a peek at healthcare costs and make sure that, the healthcare costs are, have a good competition in the marketplace. Go ahead.
No, you go ahead.
In addition, I wanted to point out, though, at the same time, we might be able to benefit in our investigations by receiving certain information from the PPC that's collected through this bill. And that information, to the extent that we could receive that and conduct investigation under our authority may also give us, as a whole, help in making sure that the markets are, there's competition and they could be robust.
Okay. And is it the claims data specifically that we anticipate being in the database that you're concerned about?
Madam Chair, Mark Kruger for the record, it's not specifically the claims data. What it is going back to Section 1. It's the data regarding the cost of healthcare and particularly consolidation among entities that provide for healthcare. Okay. So it's the market data of anti-competitive behavior or competitive.
Any other questions from anybody on this specific amendment? All right, seeing none, thank you, Mr. Kruger, for spending your afternoon / early evening with us. Okay. Now we are going to go to the phone lines and open neutral testimony.
Thank you, Chair. Callers, if you'd like to give neutral testimony for Senate Bill 40, please press *9 now to enter your place in the queue. Will the caller with the last 3 digits of 691 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now. Once again, caller with the last 3 digits of 691, please slowly state and spell your name for the record. You'll have 2 minutes and may begin now.
Chairwoman Ratty and committee members, good evening. Chris Neal, representing Carfax. That's CHRIS, N as in Nancy, EAL. Thanks for the opportunity to offer testimony this evening. Carfax vehicle history products and services are powered by vehicle and event information that is completely non-personal in nature. Central to ensuring that this non-personal information is properly appended to a particular vehicle is the unique 17-digit vehicle identification number, otherwise known as the VIN. The VIN alone is a unique OEM-generated vehicle identifier that possesses no relationship whatsoever to an individual. A decoded 17-digit VIN provides characteristics specific to a vehicle's assembly, its make, model, year, and engine body style. Given our background comments this evening, Carfax submits to the committee that the vehicle identification number, or VIN, should be stricken from the current definition of direct patient identifier in Senate Bill 40. Second, and equally as important, given the construct of the current definitions of direct and indirect patient identifiers, we also would recommend that license plate number be appropriately reclassified as an indirect identifier, given its public visibility and inability to identify an individual. Carfax appreciates this rare opportunity to make comments to the Health and Human Services Committee. At this point, I would be happy to stand for questions. Thank you, Madam Chairwoman, Committee.
Thank you, Mr. Neal, and welcome to the Health and Human Services Committee. Any
Thank you, Madam Chair.
Any questions from the members on the amendment? All right, seeing none, we'll go ahead and continue on in neutral testimony.
Chair, at this time, there are no more callers wishing to testify in a neutral position for the bill.
Okay, then we're going to turn it back over to Ms. Shalhagian in closing comments and see if there are any outstanding questions from our members. So go ahead, Ms. Shalhagian.
Thank you, Chair Ratty. Sarah Shalhagian for the record. My closing remarks are similar to the last measure, and I just would be remiss if I didn't acknowledge all of the hard work that went into this measure by the Patient Protection Commission and all the stakeholders who have come together to try to improve upon the bill language. And so I stand ready for any questions, and thank you for this opportunity.
All right, members, any outstanding questions?
Madam Chair, I have one.
Senator Kieckhofer.
I appreciate it, and I apologize for not asking it earlier in the hearing. And if I somehow missed an answer to this previously, I will apologize. In Section 1, Subsection 2, the Commission is empowered to basically mandate analysis of healthcare information from local governments. Have you gotten any feedback from those local governments on that language?
Thank you for the question, Senator Kekeffer. Sarah Shalhagian for the record. I have not received any feedback from local governments on this section, but I would be more than happy to reach out and connect with them and then circle back to you.
Yeah, I appreciate it. Just that was one thing to get a report, like request an existing report or something like that, but requiring another government to do an analysis of information is something new. So I appreciate it. Thank you.
And Senator Kekeffer, Sarah Shalhagian for the record, if I can, in Section 1, it does say that the Commission may request. And so just for clarity, I'd like to point out that I believe that would happen in the form of a public meeting or a public request by the Commission, and there would be a process for that to happen. And so then the local governments would be properly notified of what the Commission is intending to request. So I don't believe it's an automatic mandate on the local governments.
Yeah, I appreciate that it could certainly be done during a public meeting. I think if the Commission itself decides to make a request, though, that second sentence is that a governmental entity from which such a report shall provide the report. So
right.
That's just stronger than we usually do. Thanks, appreciate it.
Thank you.
All right, any other additional questions? Okay. So again, I would like to express my gratitude to the Patient Protection Commission, who put in some long hours, many meetings to bring us these two concepts. Actually, I'm sorry, I should close the hearing on SB 40, and then just want to make some general comments. So again, want to express my gratitude to the Patient Protection Commission for the long, hard work that they did on bringing these two concepts forward. One focused on making sure that some of the really would have been impressive gains in terms of use and access of telehealth during the state of emergency could continue on after the emergency is concluded. And the second, making sure that we are, I think, taking a significant step forward towards the transparency of healthcare so that we can, hopefully, I think the end goal be managing costs. And so hopefully with all of the very, very, very many details that we discussed today, that those two concepts are shining through. I want to thank again Senator Spearman for getting the ball rolling on the Apcd last session. And I'm appreciating that the work has expanded across the country. She was probably bleeding edge. Maybe now we're leading edge or maybe in the middle on that concept, but happy to see this work continuing forward. And then I want to express my gratitude to all of the stakeholders and Ms. Shalhagian, who have spent quite a bit of time getting us here. You may be surprised to know, I think we've cut the content of the amendments by half from where we started. There's still quite a bit, probably still some work to be done. But that's our gift to you, that maybe we cut them down in half, but there's been a lot of good work done by a lot of people. I think more conversations to have. The last thing I would like to do is just give Ms. Shalhagian just the briefest of moments to talk about an exciting announcement today. I believe the announcement was made today about a project that the state of Nevada has been included into as just a little teaser and to encourage folks to go find out more.
Oh, thank you, Chair Ratty. Sarah Shalhagian for the record. I am happy to share the news that Nevada has been selected to participate in a multi-state collaborative effort with Peterson Milbank Foundation on a program to address sustainable health care costs. I anticipate a further deliberation at the Commission's upcoming meeting on Monday, March 15th, starting at 9 a.m. So if I can make a plug in here to have anyone follow along the Commission's work and discussion as we start rolling up our sleeves and getting to work in addressing healthcare costs in our states by implementing measures or benchmark measures for healthcare.
Fantastic. We'll look forward to hearing more about that project and following the Commission's additional work.
Great,
so
thank you.
With that, I'm going to go ahead and open it up for public comment. I'm going to limit it to 2 minutes.
Thank you, Chair. Callers, if you would like to give public comment, please press *9 now to enter the queue. Once again, to give public comment, please press *9 now. Chair, at this time, it appears no callers wish to give public comment.
All right, sounds like we've worn people out. Go Team HHS. All right, I appreciate everybody's participation in these bills. They're complex but important. With that, we will go ahead and call this meeting adjourned. Everybody have a great evening. We'll see you soon.